Hi everyone! Today we are going to discuss part 2 of the ITE 2024 Most Commonly Missed Words. I split this discussion into two parts. Part 1 is going to discuss organ-based basic and clinical sciences, while part 2 is going to discuss clinical subspecialty keywords. Our first keyword is going to be autonomic nervous system neurotransmitters. So we can put the autonomic nervous system into two different parts, the sympathetic and the parasympathetic. Your sympathetic is going to be your fight or flight, while your parasympathetic is your rest and digest. So for the sympathetic nervous system, usually at T1 to L2 of the spinal cord, the preganglionic neurons are going to be cholinergic, so they release acetylcholine at the synapse in the ganglion. Postganglionic, most are going to be adrenergic, so they release norepinephrine. But we also have a few cholinergic, especially for your sweat glands and smooth muscles of certain blood vessels. The adrenal medulla releases epinephrine. In the adrenergic synapse, norepinephrine is reabsorbed or degraded by your COMT enzyme. As you can see in the picture here, the sympathetic, so we have a preganglionic neuron, acetylcholine. Here's our postganglionic neuron. Mostly releases norepi, except for acetylcholine for sweat glands, epinephrine for the adrenal medulla, and those have their effect on our target cell. The parasympathetic, rest and digest, is craniosacral, so brainstem nuclei, so cranial nerves 3, 7, 9, 10, as well as S2 through S4. Preganglionic neurons, same as our preganglionic neurons in the sympathetic system, release acetylcholine at the synapse in the ganglion. However, the postganglionic neurons all are cholinergic and all release acetylcholine. At the cholinergic synapse, acetylcholine is degraded by the enzyme acetylcholinesterase, or it's reabsorbed into the preganglionic neuron. Airway resistance, lung volumes. So airway resistance is the degree of resistance to airflow through the respiratory tract during inspiration and expiration. How much resistance occurs in the respiratory tract depends on airway diameter and whether the flow through the airway is laminar or turbulent. So laminar flow is a state of flow in which air moves through a tube in parallel layers with no disruption between the layers, and the central layer is flowing with the greatest velocity. It's important to note this equation for airway resistance. So airway resistance is equal to 8 times length times gas viscosity divided by pi times radius to the fourth. It's important to note that airway resistance is inversely proportional to the radius to the power of 4. Therefore, if you make a small change in the diameter, that has a huge effect on the resistance of an airway. So for example, if you half the radius of an airway, you would cause a 16-fold increase in resistance. Turbulent flow is going to be when air is not flowing in parallel layers and it moves in a more random movement of gas particles. This usually occurs at branch points or sharp angles. It's directly proportional to gas density and inversely proportional to the fifth power of radius. So turbulent flow is sensitive to airway caliber. It's also important to note the Reynolds number. So this Reynolds number is going to differentiate laminar from turbulent flow. If your Reynolds number is less than 1,000, it's more likely to be laminar, and if it's greater than 1,500, you're more likely to have turbulent flow. The equation for Reynolds number is linear velocity times diameter times gas density divided by gas viscosity. Now, how does this apply to lung volumes? So at your low lung volumes, you lose radial traction. Radial traction in itself helps prevent airway collapse. And if you lose your radial traction, that increases the contribution of your small airways to total resistance. So therefore, your airway resistance becomes inversely proportional to lung volume. So in order to combat this, we can increase our lung volume up to normal with PEEP, and that can reduce our airway resistance. Autonomic dysreflexia is usually caused by a spinal cord injury at the level of T6 and above. It's very unusual for it to occur in patients with a spinal cord injury below the level of T10. So autonomic dysreflexia occurs due to the interruption of a normal descending inhibitory impulse in the spinal cord. So let's look at our example. So we have a picture here of a spinal cord injury at the level of T6, and we have an efferent stimulus from a full bladder. So what happens is we have this afferent stimulus that causes a massive sympathetic response. This response causes widespread vasoconstriction, which causes hypertension. This signal is then able to go up the spinal cord to the brain, where the baroreceptors in the blood vessels detect a hypertensive crisis, signals the brain. So then, from the brain down, we get a heart rate becomes slowed. However, the rest of the signals are unable to pass from the brain down the spinal cord below the level of T6. So they essentially become blocked. So what happens to the patient is that above the level of the spinal cord injury, you end up with vasodilation, headache, flushing, sweating, nasal congestion, and a reflex bradycardia due to the parasympathetic response. And below the level of the spinal cord injury, you end up with profound vasoconstriction and hypertension. Blood transfusion infection rate. So transfusion infections can occur from bacteria, viruses, parasites, and prions. For bacterial infection, most commonly going to be due to bacterial contamination from platelets. 1 in 2,500 platelet transfusions can cause an infection. However, only 1 in 70,000 to 1 in 118,000 platelet transfusions are actually clinically significant. Viral contamination of blood is actually rare due to donor screening and blood testing. However, there are some viruses that can occur. So ZMV can be transmitted by white blood cells in transfused blood. However, if it's leukoreduced blood that you're transfusing, that significantly reduces the risk of CMV transmission. Hep B and Hep C virus, the risk of transmission is about 1 in 277,000 for hepatitis B and 1 in about almost 2 million for hepatitis C. Screening for hepatitis C has been mandatory since 1972 for Hep B and 1992 for Hep C. For HIV, risk of transmission is about 1 in 1.5 million transfusions. And then for the human T-cell leukemia virus 1 and 2, this is going to have a risk of transmission which is very low, which is 1 in 3 million transfusions. You should also note that in the United States, all blood is going to be screened for the following pathogens. So Hep B, Hep C, HIV 1 and 2, HTLV types 1 and 2, syphilis, West Nile, Chagas disease, but that's first-time donors only, CMV for select immunocompromised recipients, and Babesia, which is only in Babesia endemic regions. Parasites can also be transmitted, mostly from malaria, in patients that have latent disease. So donors are screened and deferred for 3 months if they had visited a malaria endemic country, or 3 years if they have lived in a country in which malaria is considered endemic. And prions is a transmissible spongiform encephalopathy, so there is a theoretical risk of transmission via blood transfusion. So there are restrictions on donations from patients that have had family members with prion disease. Our next topic is coronary arteries and resulting heart block. Coronary artery disease with and without a heart attack is one of the most common causes of heart block. There are different types of heart block. So you have first degree, second degree, there are 2 types, and then third degree heart block. So for first degree heart block, it's usually mild. Your conduction is slowed, but the signals reach the ventricle. Your PR interval is greater than 200 milliseconds, and no treatment is needed. For second degree heart block, there are 2 types. So Mobitz type 1, which is Monkey-Bach, and Mobitz type 2. For Mobitz type 1, you have a progressive prolongation of the PR interval, which leads to a non-conductive P wave. Usually no treatment is needed, and this one is associated with an inferior MI. For Mobitz type 2, you have intermittent non-conductive P waves without the progressive prolongation of the PR interval. This one's usually caused by an anterior MI, and these patients need a permanent pacemaker placed. Third degree heart block is where you have severe bradycardia due to absence of AV conduction. You end up with AV dissociation, and a permanent pacemaker is needed to treat these patients. For third degree or complete heart block, this is most likely caused by an inferior wall MI from your RCA, and 85% of the population can damage the AV node. Prevention of diffusion hypoxia, also known as the Fink effect, usually occurs when you're using nitrous at the end of your case. When your nitrous is stopped, it diffuses back to the alveoli from the blood. Then you end up with a dilution of inspired oxygen concentration. You end up with a decrease in arterial CO2, which leads to a reduction in your respiratory drive. Therefore, in order to prevent the diffusion hypoxia, you need to apply 100% oxygen after you stop nitrous for about 5 to 10 minutes. Potassium-sparing diuretics, so these are weak diuretic agents. They do not increase potassium excretion. They inhibit sodium reabsorption in the collecting tubules. So our first group are going to be the competitive aldosterone receptor antagonists. So these bind aldosterone receptors in the collecting tubules. They inhibit aldosterone-mediated sodium reabsorption and potassium secretion. So their side effects are going to be hyperkalemia and metabolic acidosis. The next group of potassium-sparing diuretics are the non-competitive group. So these inhibit sodium reabsorption and potassium secretion by decreasing the number of open sodium channels in the luminal membrane of the collecting tubules. Amiloride may also inhibit the sodium-potassium ATPase in collecting tubules. So side effects, again, hyperkalemia and metabolic acidosis. Both of these can cause nausea, vomiting, and diarrhea, but amiloride also has fewer side effects. The Glasgow Coma Scale, or GCS, is used to describe the extent of impaired consciousness in all types of acute medical and trauma patients. This scale assesses patients according to 3 different aspects of responsiveness, so eye-opening, verbal response, and motor response. You should note that the GCS can be used in children older than 5 with no modification. Younger children and infants will have a more difficult time obeying commands and verbal responses, so you would have to use a different scale. As you can see from the chart, eye-opening is scored from 1 to 4, verbal response is scored from 1 to 5, motor response is scored from 1 to 6. And the GCS has a score from 3 to 15, with 15 being normal. A mild injury is a score between 13 and 15. Moderate injury is a score between 9 and 12, and severe is between 3 and 8. One of the mnemonics we use for GCS is less than 8 intubate, and this is because there's a loss of protective airway reflexes and impaired central regulation of respiratory drive. So patients with a GCS less than 8 would benefit from a prompt intubation. All right, so next up is hepatic synthesis clotting factors. So the liver synthesizes most of our clotting factors. So fibrinogen, which is 1, prothrombin 2, factors 5, 7, 9, 10, and 12, protein C and S, and antithrombin. Your liver endothelial cells produce factor 8 and von Willebrand's factor. If your liver has decreased capacity to synthesize proteins, causes decreased blood levels of your clotting factors in patients with liver disease. So the activity or concentration of these coagulation proteins is a useful test of liver function, and that can guide your prognosis. It's important to note that vitamin K is a fat-soluble vitamin that helps blood clot properly. 4 of the 9 factors produced by the liver cell are vitamin K dependent, including factors 2, 7, 9, and 10, and the factors of the so-called prothrombin complex. It's important to understand the differences between hypokalemic periodic paralysis and hyperkalemic periodic paralysis, but in today's discussion, we're going to discuss hypokalemic periodic paralysis. This is a rare disorder that causes severe muscle weakness. Your diaphragm is spared, usually triggered by strenuous exercise, high carbohydrate diets, glucose infusions, and insulin, and sodium-rich foods. It's important to note that this is a mutation in the L-type calcium channel, and less commonly the voltage-gated sodium channel. You can have episodes of hypokalemia can cause weakness because you end up with partial depolarization of muscle cells without an action potential. So how would we manage these patients intraoperatively? So you would monitor their potassium levels and avoid glucose-containing solutions or solutions with high sodium content. It's important to note that you can use succinylcholine in these patients. So myotonia congenita is a genetic neuromuscular channelopathy which develops in childhood, which affects the skeletal muscle fibers, which is the somatic nervous system. So what is myotonia? It's a delay or failure or relaxation in contracted skeletal muscle with prolonged rigidity. So you have stiffness, cramping, and muscle hypertrophy. This is caused by mutations in the CLCN1 gene that encodes proteins to form voltage-gated chloride channels in the sarcolemmal membrane. The mutation causes hyperexcitability of skeletal muscles, resulting in repetitive depolarization and myotonia. Neuromuscular junction ion flow is extremely important for muscle contraction. Synaptic transmission at the neuromuscular junction begins when an action potential reaches the presynaptic terminal of a motor neuron. This then activates voltage-gated calcium channels and allows calcium ions to enter the neuron. Calcium ions then bind to sensor proteins on the synaptic vesicles, which triggers the vesicle fusion with the cell membrane and subsequent neurotransmitter release from the motor neuron into the synaptic cleft. Motor neurons release acetylcholine, which is a small molecule neurotransmitter, which then diffuses across the synaptic cleft and binds to nicotinic acetylcholine receptors on the cell membrane of the muscle fiber. The binding of acetylcholine to the receptor can depolarize the muscle fiber, which causes a cascade and eventually results in muscle contraction. Our next keyword is going to be effects of pituitary hormones. So the pituitary gland is going to have two lobes, the anterior lobe and the posterior lobe. Each lobe is going to produce different hormones. The anterior lobe produces growth hormone, prolactin, TSH, ACTH, FSH, and LH, while the posterior lobe is going to secrete antidiuretic hormone and oxytocin. So for the anterior lobe of the pituitary, growth hormone is going to be involved with growth of body tissues, prolactin, milk production from mammary glands. Your thyroid stimulating hormone stimulates thyroid hormone release. The adrenocorticotropic hormone stimulates hormone release by the adrenal cortex. Follicle stimulating hormone stimulates gamete production, and luteinizing hormone stimulates androgen production in the gonads. Your posterior pituitary releases two hormones, antidiuretic hormone and oxytocin. Antidiuretic hormone stimulates water reabsorption in the kidneys, while oxytocin stimulates uterine contraction during childbirth. Renal replacement therapy mechanisms. First, we're going to discuss indications. So the most known acronym is AEIOU. So A stands for acid-base problems, E, electrolyte problems, I, intoxications, O for overload of fluid, and U for uremic symptoms. On the left-hand side of the page, I have a list of different indications that you can read through. But how does renal replacement work? So your blood flows from the body into a dialyzer where it becomes filtered. There's a solution that enters the dialyzer and draws waste out of the body. This then used solution is pumped out of the machine and discarded. The patient's clean blood then goes through a pressure monitor to make sure that there is no air in the blood. Blood then is returned through a second IV attached to the body, and the dialysate is made up of water, electrolytes, and salts. Cerebral effects of the sitting position. So significant changes can develop when patients are moved to the sitting position. The patient's mean arterial pressure, central venous pressure, stroke volume, and cardiac output all decrease. When the patient is not under anesthesia, these effects are compensated for by an increase in your systemic vascular resistance by up to 50 to 80%. However, this autonomic response is blocked by our vasodilating anesthetics, which further exacerbate and compromise cardiac output. So the physiologic effects from the sitting position can be hypotension because you get the decreased venous return. You also have that blunted sympathetic nervous system response in the anesthetized patients. So the patients cannot increase their systemic vascular resistance to increase their pressure, to increase their blood pressure. You can also have cerebral hypoperfusion is a risk because your head is elevated above the heart. So in order to prevent cerebral hypoperfusion, we need to think about our cerebral perfusion pressure. You can calculate your cerebral perfusion pressure from the equation MAP minus ICP or CVP, whichever one is higher, to figure out what the patient's cerebral perfusion pressure is. Your CPP can decrease by 15% in the sitting position in the non-anesthetized patients and can further decrease under anesthesia because of vasodilation and impaired venous return. You should also consider cerebral autoregulation for these patients. Patients who have chronic hypertension have a shift in their cerebral autoregulation curve and actually will need a higher perfusion pressure or a higher MAP in order to perfuse the brain. So for these patients, it's very important to figure out where we are going to take our blood pressure. If we have patients who are in the seated position who are sick, it's important that we place arterial lines with our transducer at the level of circle or Willis. Or if we have a non-invasive blood pressure cuff, it's important to keep our mats on the higher side. As you can see from the picture that I have here on the right, there is a conversion factor. So a centimeter rise is equal to a 0.75 millimeter mercury drop in MAP. So depending on how far your non-invasive cuff is from your brain determines what your MAP reading will be. As you can see in this picture, if we have a 20 centimeter rise in height, equates to a 15 millimeter drop in your patient's MAP. So at the circle of Willis or in the brain, our MAP is only 50, while our MAP on the cuff is 65. So it's important to think about these different types of monitoring abilities in order to adequately perfuse the patient's brain. So TURP complications is our next keyword. So what is TURP syndrome? So TURP syndrome is a symptomatic hyponatremia with excessive intravascular volume and edema from absorbing the hypotonic irrigation fluid that's used during this procedure. There are different types of fluids that can be used. So you can use glycine, sorbitol, mannitol, and normal saline. Glycine is the most universally used irrigation solution. They use it because it's non-conductive, it's non-hemolytic. However, it is hypotonic. And it can also inhibit neurotransmitters in the retina, which can lead to deterioration of vision and can lead to retinal dysfunction and blindness. So this side effect is extremely important to know. Saline can also cause hyperchloremic acidosis due to excessive chloride content, and the cytol solution, which is sorbitol and mannitol, become metabolized to fructose and can cause harm to patients with a fructose hypersensitivity. You should know that one of the most common electrolyte disturbances from a TURP procedure is hyponatremia. Our next topic is tourniquet deflation effects. In anesthesia, we mostly use tourniquets during orthopedic procedures. So during these cases, what are some effects that we can see after they deflate the tourniquet? So multiple effects can be seen due to the return of blood from the ischemic limb back into the systemic circulation, as well as blood flowing back into the ischemic limb. So tourniquet deflation can affect our hemodynamic parameters, our respiratory system, our neuro system, our temperature, our metabolic system, and our heme. So hemodynamically wise, your CVP, MAP, and afterload all decrease. You would treat that with vasopressors and volume. Respiratory wise, blood in your ischemic limb is hypercarbic, so that will lead to an increase in your PaCO2 and your end-tidal CO2. You would treat this by increasing your minute ventilation. Neurologically, that increase in end-tidal CO2 can lead to an increase in cerebral blood flow. Temperature wise, you have ischemic hypothermic blood returning to the heart, which can then decrease your core body temperature. Metabolically, your blood has an increase in lactic acid, CO2, and potassium. The effects of that can be seen post-deflation in the blood for up to 30 minutes. And heme-wise, there's an increase in TPA, or your tissue plasminogen activator levels, which can lead to an increased AT3 and thrombomodulin phospholipase C that can lead to post-deflation bleeding. Transfusion, electrolytes, and complications. This is a large topic, which I've split up into the next two slides. So blood transfusion themselves can lead to electrolyte changes, hypothermia, infection, and blood transfusion reactions. So some electrolyte changes you may see are hypocalcemia, hyperkalemia, and hypokalemia. Hypocalcemia, due to citrate, which is preservative added to blood, binds with the patient's endogenous calcium and makes it inactive. This is associated with hypotension, QT prolongation, and negative ionotropy. Hyperkalemia occurs due to leakage of potassium from red blood cells in stored blood. This can lead to cardiac arrest and EKG changes. You can also see hypokalemia. Potassium is taken up into cells after transfusion, which is also combined with the release of aldosterone, antidiuretic hormone, and catecholamines in response to stress, which can then lead to a decrease in potassium. Another complication can be citrate toxicity. So hypothermia in connection with a large amount of citrate that's found in transfused products can cause decreased hepatic metabolism of citrate. Also, citrate is converted to bicarb in the liver, and this can cause a metabolic alkalosis. Hypothermia is a more common complication of blood transfusions because blood products are usually stored at cold temperatures. So transfusing these blood products, we should put these through a blood warmer if we can. It's important to avoid hypothermia because hypothermia worsens hypocalcemia and acidosis, which can also lead to the lethal triad of trauma, which is hypothermia, acidosis, and coagulopathy. Other complications include infection, so bacterial and viral, which we talked about earlier in the presentation. And then two other blood transfusion reactions that I wanted to touch on briefly are TACO and TRALI. So TACO is the most common cause of transfusion-related mortality. You have a pulmonary edema due to excess volume or rapid transfusion. And then the other one is TRALI, which is an acute lung injury and a non-cardiogenic pulmonary edema. It's very important that you distinguish this as a non-cardiogenic pulmonary edema. Highest risk with plasma-containing products donated from pregnant females due to HLA autoantibodies. So we've all placed central lines. So how do we prevent infection? Infection is the most common late complication of a central line. It occurs in 5% of patients that has one. So how do we prevent it? We can prevent it in two ways, either with placement and removal. So placement, we want to do it under aseptic technique. So you need a full sterile drape, sterile gown and gloves, hat and a mask. If you're using the ultrasound, also use an ultrasound probe cover. Single lumen catheters have a lower infection rate. Heparin-bounded catheters reduce thrombosis and infection. You should use antibiotic-impregnated catheters, can reduce catheter colonization and bloodstream infection. And the biopatch is important. It's a chlorhexidine impregnated patch that goes right over the catheter. And you affix the patient with a tegaderm on top. And then it's also important to remove the central lines as soon as possible. So when your patient no longer needs the central line, it should be removed. Our next part of the presentation is going to deal with clinical subspecialty keywords. Cyanide toxicity treatment. So cyanide toxicity occurs from inhalation of smoke from fires, industrial exposures within metal, plastic, and agricultural industries, and prolonged administration of nitroprusside. So how does one get cyanide toxicity? So cyanide reversibly binds to ferric ion and cytochrome oxidase A3 within the mitochondria and inhibits oxidative phosphorylation and aerobic respiration. This mechanism is extremely important to know and understand for your upcoming exam. An arterial blood gas, so an ABG, should be collected to measure pH and assess serum lactic acid levels. You should note that an ABG will show a normal PaO2 and SaO2 and an elevated serum lactic acid concentration. So how do we treat these patients? So you want to give them 100% FiO2. You want to stabilize their airway, breathing, and circulation. We can decontaminate them and stop nitroprusside if that was the cause. First line treatment is going to be vitamin B12 or hydroxycobalamin. It's first line. It binds to cyanide. It turns cyanide into cyanocobalamin, and then it's extruded in the urine. If you're going to give it IV, you give 5 grams IV, and if it's a cardiac arrest, then you give 10 grams IV. Sodium thiosulfate is no longer recommended as a single antidote because it has a slow onset, and sodium nitrate can also be used, but do not use this particular drug if you have an inhalational injury. Next, we're going to talk about drowning and focus on neurologic outcome. So 20% of non-fatal drowning victims have some type of neurological damage, most commonly from a hypoxic ischemic injury from hypoperfusion and hypoxemia from cardiac arrest after the drowning. We can have cerebral edema and intracranial pressure elevation, sometimes observed 24 hours after the injury, and this will reflect the severity of the neurologic insult rather than its cause. Drowning itself can cause irreversible brain damage to the hippocampus, your basal ganglia, and cerebral cortex within 4 to 10 minutes. This damage is called an anoxic brain injury and affects parts of the brain that controls memory, speech, and movement. Survivors of drowning usually suffer from deficits in these areas. Gabapentin mechanism of action. Gabapentin is an anti-epileptic medication which can also be used to help with neuropathic pain. It works by decreasing central sensitization through bonding to the alpha-2 delta subunit of the voltage-gated calcium channels and modulates the central nervous system gamma-aminobutyric acid activity. If you have a patient who has moderate or severe neuropathic pain from postherpetic neuralgia or possibly painful diabetic neuropathy, oral gabapentin is recommended at 1,200 to 3,600 milligrams a day for 4 to 12 weeks. For this topic, lactation analgesic effects, I didn't really know what they were looking for this. So I'm just going to let you know that paracetamol, ibuprofen, naproxen, and codeine are considered safe analgesics to take while breastfeeding because they transfer little into the breast milk. Non-shivering thermogenesis is heat production due to metabolic energy transformation by neonates. Non-shivering thermogenesis relies on brown fat. Neonates produce heat through the metabolism of brown fat by shifting hepatic oxidative phosphorylation to a more thermogenic pathway. Brown fat in itself is highly vascularized and has a rich sympathetic innervation. B3 receptors are triggered by norepinephrine during cold stress. This cold stress then increases lipase activity in the brown fat and then results in a release of free fatty acids. Therefore, heat produced by non-shivering thermogenesis is mainly a byproduct of fatty acid metabolism and to a lesser extent from glucose metabolism. Pregnancy anticoagulants. So which anticoagulants should we be using in our patients who are pregnant? So heparins are most used because they do not cross the placenta and do not result in fetal anticoagulation. Low molecular weight heparin is preferred over unfractionated heparin for all but the final weeks of pregnancy. These heparins are easier to administer and are more predictable, and low molecular weight heparin has a lesser risk of hit. Unfractionated heparin is used when your creatinine clearance is less than 30. Warfarin should be avoided during pregnancy because it does cross the placenta, is a teratogen, and causes fetal anticoagulation. Exposure to warfarin in early pregnancy can result in embryopathy, while exposure later in pregnancy can cause fetal bleeding, including intracranial hemorrhage. An exception is an individual who's especially at high risk for thrombosis or thromboembolism, especially those patients who have mechanical heart valves. So how do we diagnose septic shock? So first we're going to start off with the definition of sepsis. So sepsis is a life-threatening organ dysfunction that's caused by a dysregulated host response to an infection. Organ dysfunction is an acute change in your total SOFA score with a score greater than or equal to 2 points. When sepsis-induced hypotension remains refractory to your initial fluid resuscitation, the patient goes into septic shock. Septic shock is also a distributive shock. So distributive shock is a hyperdynamic state due to decreased afterload and preload. So we can tell that a patient is in shock when you have an infection that's causing a vasopressor requirement to maintain a MAP greater than 65 despite giving your fluid, plus a serum lactate greater than 2. Tumescent liposuction is a technique that uses large volumes of dilute solution of lidocaine with epinephrine and normal saline with the goal to swell and harden the target tissue. Your peak plasma concentration of lidocaine occurs within 1 to 2 hours after injection. Vasoconstriction from the dilute epi reduces the procedural blood loss and slows the uptake of the local, resulting in decreased peak plasma concentrations. Infiltration should occur at least 10 minutes prior to the procedure. You should also note that the safe dose of lidocaine using the tumescent technique with epi has reported to be 35 milligrams per kilogram, with some advocating as high as 55 milligrams per kilogram. Our last keyword for part 2 is signs of physician substance use disorder. So addicted anesthesia care providers can appear quite functional early on in the course of the disease and often remain extraordinarily tentative at work. So some of the following changes in behavior are noted. So they withdraw from family and friends, mood swings, they have increased episodes of anger, they actually spend more time at work even when they're off, they volunteer for extra call, they don't like to take lunch or coffee breaks, they sign out increasing amounts of narcotic or quantities that are inappropriate, especially on a Friday or before vacation. They might get intoxicated at social functions, and they can also have a risk for DUI or behavior while intoxicated. So this was our last keyword. I hope that this was informative and helpful, and I wish you all the best on your upcoming exams.